Mariko Makino from Toho University, Japan, and the title of the lecture is The Outcome of Eating Disorders, Longitudinal Study, Pregnancy, and Afterbirth.
Thank you very much.
Makino, the floor is yours. Okay.
Yes. So I would like to speak. Title is The Outcome of Eating Disorders. There is no conflict of interest. Background. Eating disorders are common mental disorders developing during puberty, as well as pregnancy and afterbirth, because they undergo major physical and emotional changes. Followed ED patients for a long time, and we reached their recovery and found some interesting outcome. Eating hypothesis. Eating disorders were influenced by pregnancy and delivery. Hypothesis 2, postpartum women experienced body shape changes. This might lead to postpartum depression. The aim of our study to identify relapse of eating disorders during pregnancy and after delivery, as well as postpartum depression in women who had complete remission of eating disorders. Other influenced factors related to remission and postpartum depression were discussed. Method, participant. I had seen around 1,000 patients for 10 years, and 55 experienced ED remission and pregnancy and delivery. Among them, 25 consented to participate in this study. 24 eating disorders, 21 with bulimia nervosa, 4 with anorexia nervosa. But actually, we analyzed 24 eating disorders because one patient had miscarriage. Method, defined remission criteria and tools. There is no defined remission with DSM-4 or 5 or something like that. So according to the literature, we made 6 months for remission. And EAT26 and EPDS Japanese version were used. Method, this is inclusion criteria. EAT26 less than 9. Normal eating behavior, ability to perform daily activities without restriction, some social participation, etc. This is exclusion criteria, EAT26 over 9, and complications arising from psychiatric disorders such as schizophrenia, extreme dependency, obsession with food, preoccupied with body shape and weight, irregular or no menstruation. Method. This is an example for interview questions during pregnancy and after delivery. Patients were interviewed every 2 weeks, both during pregnancy and after giving birth. We made 2 groups, temporary relapse group and non-relapse group. Temporary relapse group means eating disorder relapse during pregnancy. 16 patients showed temporary relapse. However, they recovered 3 months after conceiving. And we compare these 2 groups as for postpartum depression rate. Statistical analysis using a 2-sided unpaired test. Result 1, characteristic of women recovered from eating disorders. Temporary ED relapse during pregnancy and ED relapse after delivery, postpartum depression rate were very higher than we had expected. This is comparison between temporary ED relapse and non-relapse group. Infant weight was heavier in non-relapse group, and temporary ED relapse group had ED relapse after delivery compared to non-relapse group. Comparison between ED temporary relapse group and relapse group after delivery. Non-relapse group, age at remission, age at pregnancy, ED relapse during pregnancy, and vaginal delivery had a significant difference compared to temporary relapse group. Result 4. Comparison between postpartum depression group and non-depression group. Non-depression group, infant weight were heavier. There is a marginal difference. Result 5. Family support. No items have significant difference between family support and non-support group. Complication in pregnancy. Although our sample size was very small, as you can see, many complications were found. For example, 5 patients, gestational diabetes mellitus, 3 anemia, 2 threatened miscarriage. Result. Temporary ED relapse 67%, postpartum depression 50%. Non-relapse group, infant weight was heavier than relapse group. ED relapse after delivery, temporary ED relapse group were higher. All of the non-relapse group experienced vaginal delivery. Infant weight, non-depression group had more weight infant than depression group. Relapse were not during pregnancy. Our results showed temporary relapse 67%. Among temporary relapse group, 67% relapse eating disorders. However, they recovered within 3 months. We thought they were counseled every 2 weeks. I think counseling play an important role, so counseling could be effective to prevent them from relapsing eating disorders. Second, relapse group and non-relapse group, maternal complications were same rate. So we thought eating disorders may be high risk for maternal complications. Non-relapse group, postpartum depression was lesser and infant weight was heavier. To prevent ED relapse was crucial, we think. Postpartum depression rate, relapse group and non-relapse group was same. The reason is unclear. Infant body weight, no difference. So we thought the first 3 months of the pregnancy are not crucial for the final weight gain. Discussion. Postpartum depression. The rate of postpartum depression and complication were found to be the same between relapse and non-relapse group. So we thought eating disorders were vulnerable groups for depression at the life events. And next, infant body weight. Postpartum depression group had lesser body weight than non-depression group. We thought to prevent them from suffering from depression was contribute significantly for the child growth. Difference between anorexia nervosa and bulimia nervosa. Our samples, all anorexia nervosa and 48% of bulimia nervosa experienced temporary relapse. And we thought anorexia nervosa were more conscious of their body shape. This is same as the previous studies. According to the previous studies with anorexia nervosa, they have low birth weight infant. And third, according to Japanese report, average infant body weight should be around 3,000 grams for males and females. Our result was around 3,000 grams. There was no significant difference. This is because the sample size was very small. The reason is still unclear. Discussion. Maybe you know Barker hypothesis. Intrauterine growth restriction or low birth weight infant has a causal relationship with the origin of hypertension, coronary heart disease, and non-insulin dependent diabetes in middle age. Thus, follow-up low body weight infants was important to prevent them from suffering from these diseases in the middle age. Infant weight again. According to the literature, the majority of the women with active eating disorders had normal pregnancies, resulting in healthy babies. Our results are similar. It may be said that infants of women with temporary relapse during pregnancy or those with a history of eating disorders tend to have normal weight infant. According to Nassarin, maternal depression was associated with low birth weight infants. Our results showed the same. Infants of women in the depression group had lesser body weight than in the non-depression group after delivery. So, supporting women with low body weight infants may prevent them from suffering from depression. Discussion: disordered eating in pregnancy and postpartum depression. In Japan, among healthy women, the rate of postpartum depression rate is 10%. Compared with healthy women, our results showed that pregnant women with a history of eating disorders had a higher prevalence of postpartum depression, and they required long-term follow-up. Discussion: family support influence. We cannot find any difference between support group and non-support group. As for the reference, this is Japanese named Makino. Eating disorders relationship with family was sometimes serious and complicated, so the duration of ED recovery might be longer than non-support group, she said. Limitation of our study. Small sample size. A larger group size have increased the power to allow for comparison between two groups. I mean temporary ED relapse group and non-relapse group. And second, the information and the result of our study were extracted rather than planned for the longitudinal study. Other limitation was the absence of the group without counseling during pregnancy and after delivery, but it is very difficult to prove counseling effect. Conclusions. Our result could have supported our hypothesis. Our results could have supported our hypothesis that women with a history of eating disorders are susceptible to relapse during pregnancy and delivery and have postpartum depression. The recurrence of eating disorders were higher in the pregnancy period and after delivery. Occurrence and postpartum depression were higher in this study. Eating disorders need to be closely monitored during pregnancy and after giving birth. This is our conclusions. Thank you so much for taking the time to join today. I am very glad to see you. And if you have any questions, please contact me because I am not native English speaker. So it is difficult to listen to your questions sometimes. And please email me. This is all small letters, Gmail. Please contact me. Thank you very much.